From all these clinical lectures that look a little bit intensive. So if you have the basis of virology and try to put up the clinical picture with it, it will start making sense. And many a times I remember I give assignment to the students and ask them to come up with ideas. So that's what probably I mean if you want to think outside the box. So that's a picture for you coming up with an idea. Anyway, today we'll talk about RNA viruses. So RNA viruses, we're talking about DNA viruses, RNA viruses, and I will just pick up prototype viruses to give you the basic information. So we will talk about polio, which is an enterovirus, and common cold, as the word suggests. Couple of questions that you know, especially for the etiology and some of the characteristics for the structure of that. I just want to emphasize and tell you that it's important for us to know whether the viruses are naked or they have a envelope there. So in this case, especially for the RNA viruses, the correct answer is both A and B. And then when we talk of the positive sense RNA viruses, you have to keep in mind that they basically come up with a code that is a RNA-dependent RNA polymerase. And these polymerase are those enzymes that this virus bring it in so they can start utilizing your cell's ability to make macromolecular synthesis. So that's the incorrect answer. There are quite a few important positive sense RNA viruses, and these are some of the important ones: Picorna, Calici, Astro, Toga, Flavi, and coronavirus. You will see these words very commonly even in media as well. So let's begin with the first one, Picorna, and as I said, Pico basically means small because it's a small virus. And the nuclear material it has is a ribonucleic acid, so RNA, and this is non-enveloped. So that's another important thing that you have to keep in mind, and that is an important virus because it does affect both humans and animals as well. And not today, but Monday we'll talk about the viruses that basically are infecting both humans as well as animals. So we have this swine flu and bird flu and chicken flu and that flu. That's because we share some of the infections that we normally have. As a family for Picorna, you can see that if a virus is non-enveloped, so there is no glycoprotein layer over there, and it is acid stable. Most of the enteroviruses are acid stable, so you have to ingest them and they can survive. And then again, they are also resistant to low pH. And some of them are polio virus, Coxsackie virus, ecovirus, and enterovirus. I'm pretty sure that those of you who are very fond of the news media, enteroviruses keeps on making news. There was a big news last fall till the beginning of this year. That wasn't a single state in US where there were not people infected with enterovirus. So, and the symptoms that enterovirus were showing was respiratory system. So it wasn't a stomach flu. So even if you Google, you'll see that there are a lot of mainstream media news on enterovirus 68. And then again, as the name suggests, rhinovirus, cardiovirus. In RNA viruses, one of the most important viruses that we'll discuss is hepatitis A virus. And I was told that normally it used to be on the travelers list. If you were to travel to Asia or Africa, you need to get vaccinated for hepatitis A virus, but they started vaccinating people in this country as well. And there are many reasons for that, and we'll discuss that when we talk of hepatitis virus. So hepatitis A is an RNA virus as compared to the rest of the hepatitis viruses, which are DNA viruses. Sometime, as one of your friends just told me, the Legionnaire's disease, the name of a disease or virus is picked up. For example, upstate New York, there's a city called Coxsackie. And this was in this place they found out in early 1947, there was an outbreak in upstate New York, and that's where they first began to see Coxsackie virus. It was not that they discovered the virus. Virus pretty much was there already. What they noticed was that they used to see these babies, and these babies used to come with hand, foot, and mouth disease. So if you look at their clinical picture, many times viruses, they present as a skin lesion or mucous membrane lesion. So they were very painful, red blisters in the throat and the tongue, gums, palate, and then again you can see palms of hands and soles of feet. I told you the other day, usually you should not have any skin lesion or rashes on palms and soles because the skin is tight. The other important thing that these babies had, we call herpingina. Herpingina basically was an infection of the throat where the throat looks like red ring blisters and ulcers. It's a very painful condition, especially for the babies, because they can't even explain to you what's going on as compared to adults. They also have hemorrhagic conjunctivitis, so the kind of bleeding. It's not a pink eye, because pink eye will just suggest a color, but it's actually blood oozing out and with enormous pain. So like all other viruses, enteroviruses also comes up with an affinity for neurons. So you will see that in some of the unique properties that I'm going to discuss today for coronaviruses. Again, small positive RNA, we talked about the resistance. And then again, if it's resistant to stomach acid, of course, it's going to be resistant to your detergents and mild sewage treatment and heat, because it can survive at body temperature. Rhinoviruses, though, are labile, so you cannot ingest them, so they will die. They want to live at, sometimes you wonder, why is it that some people get stomach flu and some people got respiratory flu or some kind of respiratory system? That depends upon the ability of that virus or preference of that virus to find a place and survive. So this virus, especially rhinovirus, rhino means rhinitis, nose. So it wants to stay in the nasopharynx. And then again, all you need to do is a naked genome, which is sufficient for infection. Virus replicates in cytoplasm. And then again, there is a viral RNA which gets translated into polyprotein. And then they have, most of these viruses are cytolytic. This means they're going to enter a cell and destroy the cell. So pretty much the same theme that we were talking about viruses as a whole. Now, again, enteroviruses, most of them, they would enter either through oropharynx or nasal pharynx and then lodge into either upper respiratory tract or be carried by lymphatic system to the rest of the body. And same important concept in terms of pathogenesis, that these viruses have receptors, especially where they want to attach to. Some of the receptors which are present on the cells, like in this case we have a immunoglobulin superfamily, ICAM1. What does ICAM stand for? Okay, so that was a Google or it was you? Just you, okay. So these are adhesion molecules. ICAMs are adhesion molecules. They want to adhere to that. And why we want to know that? Because we can block that. So we can block the entry of viruses as one of the treatment that we may have. The other important thing in this particular virus is that I've been so far saying that it's your immune system that causes that pathology responsible for the disease. But in this case, a viral itself is responsible for the tissue injury that you normally get, not the response of immune system. And the other important thing that you will see is that as I said yesterday, the virus is hidden in the cell. So it's going to jump to the next cell. So we got an escape for this virus to appear in the blood or secretions. And for antibodies to attach or attack a virus, it has to be either in extracellular fluid or in the blood. But if there is lysis of the cell, there may be a chance before a virus jumps from one cell to another that the antibodies can basically block the adhesion sites of these viruses. So that's why most of the time we do rely on cell-mediated immunity as compared to viral or humoral immunity. Okay, the other important thing, as we said yesterday, and you'll see me repeating it over and over again, primary viremia versus secondary viremia. The virus gets into the mucosa or lymphoid tissue, or it goes into the M cells. Does anybody know where do these M cells lie in intestine? On the top of Peyer's patches, correct. On the top of Peyer's patches. So these are like those kind of wells where these viruses will go and accumulate. And what does Peyer patches have? Peyer patches are part of MALT, mucosa-associated lymphoid tissue. So there where you have antigen-presenting cells and B and T cells are there. Okay? So that's the whole idea, regardless of what portal of entry these viruses have, especially starting from oral mucosa all the way to intestinal mucosa, they will be absorbed and be challenged by the immune system. So they will first go to your lymphatics, and the lymphatics will drain into blood. Okay? There's a good picture, I think it's from your book. Yes, it is from your book. So you can see from here again, generally pathogenesis of enterovirus infections, and there's a list of that. So I want you to pay attention again on the top where you have all these, I said more than 6 or 9 families. We have rhino, echo, Coxsackie, polio. So polio is considered as a prototype of enterovirus. I'm going to talk about whether it's been eradicated or not globally, but now and then we do see people coming with polio virus coming to this country. That's what we call imported cases. So they will go and replicate in oropharynx, and from oropharynx they can have either a primary viremia, go into the bloodstreams. That's what I was telling you, that if you vaccinate these people with protective antibodies, so you can block these viruses while they are in the blood before they go and attach to the target tissue. So that's one level of passive immunization, a blocking antibody. So if you don't do that, for example, and if you let them go and bind to target tissues, let's see what type of target tissues these viruses have. So you have skin. Skin is one of the largest organs in the body. That's where the viruses usually go and attach to. It has, being the largest part of the body, it has the largest lymphatic system, it has the largest immune system, it has the largest sensory system, so on and so forth. So you can see if it goes to skin, especially in the case of Coxsackie, it gives you a hand and foot disease, and you have a rash on the body, or you have harpangina. So harpangina, basically, again, that reddish color that you see. If this virus goes to attack muscle, again, example is that muscle could be skeletal muscle, cardiac muscle as well. So if it goes to cardiac muscle, you may have cardiac problems. If this particular virus, while it's the blood, because remember I told you that once a virus is in the blood, so it will go to where the bloods take this virus to. So it can go to brain, and that's where the problem for polio is. So it can go to brain. And you also keep in mind that so far I've discussed 3 tissues, and one of the common themes for these tissues is Coxsackie virus, and that's very common in little babies. Then we have meninges, covering of the brain. You have again Coxsackie there causing meningitis, and then again liver, where we have hepatitis A virus. So you can see this property of viruses to go and attach. And as I said earlier about ICAM. So if I was to come up with a therapy, if I was to develop a drug, of course I would rather develop an antibody that will stop primary viremia. So once you get a virus infection, the most important thing that you need to do is immediately diagnose it and get the antibody into the system ASAP. Because if you miss the chance, so there's a window of like 72 hours. If you miss the chance, you give this virus a chance to go and attach to the target tissue, and it will be too late. And as I said yesterday as well, for some of the viruses, that the pain comes first and the rash follows that. And sometimes you ignore the pain. And sometimes you ignore the rash. So that's what the important thing is, that you really have to be on top of that to diagnose it and get into the system ASAP. And then if the virus is replicated, the virus has been shed in stools as well. That's why it's a fecal-oral route of spread of this, especially in daycare centers, in babies. That's why hand washing and other things are important, especially for hepatitis A virus, because most of the time you get hepatitis A virus from water, or hepatitis A virus from, it's also called oral kind of a virus, where you basically drink the virus in the food, right? The other community that, especially in this part of the world, where they just started vaccinating people for hepatitis A, is again the use of water bodies. So we call it RWI. Recreational water infections. Recreational water infection, RWI, especially for people, bathing in the water, seawater, using public swimming pools, and so on and so forth. Because what's happening is that people who are going to jump into those swimming pools, so they will exchange all the viruses with every part of their body. Not only viruses, but they will also share with you their so-called normal flora, bacteria as well. Because even if they chlorinate it, chlorinate is slow in action. Right? So there always are chances that you're going to acquire if you want to jump into whatever clean water it looks like. So that's another important thing. And again, hepatitis A also is very common. They will say to you, you should not drink the water in, but I mean, once you jump into the pool, it's going to go into your mouth anyway. So that's another higher incidence. And the third incidence is in male homosexuals. Again, a very high rate of hepatitis A infections. Again, pretty much the same slide. The only difference over here is colorful. There you go. What I want you to take from this particular slide is that hepatitis A exclusively for liver. It doesn't have affinity for any other thing. And Coxsackie virus has an affinity for almost everything except liver. So this is like a question by itself, and then virus is shed in feces. So once you are there using all these public facilities, there's always a danger for you and to pick up a virus. And then again, there's an incubation period. So you may pick it up and show it up later. Okay, now enterovirus, again, as I said earlier as well, the challenge is especially polio. I'll discuss that in a while. I just told you that polio is a virus that has affinity for the brain and affects that. And many a time people may get entry of these viruses and polio for all practical purposes eradicated. But those people who may have polio in the system, remember the viruses remain latent in your system. They hide and sleep in you, and they wait for the time that your immunity goes down or you get stressed out. So you may come up with many different diseases, especially for old people. So some of the viral infections are reserved for old people, but again, there always are exceptions. One such thing is post-polio syndrome. The other problem with these kind of viruses is that you may yourself be asymptomatic. So you'll think, I'm okay, and you are shedding virus. So that again is important. And the other important thing is that since this is a naked virus, as we discussed earlier, it will be resistant to environmental conditions. And we give an example for polio. Because polio basically is a classical enterovirus, and these viruses are also important not for us in terms of making a selection for whether to jump into the public swimming pool or not, but even to drink water. Because many times, especially for, I don't know whether you know that or not, the Illinois water is recirculated water. So it is coming from the sewage, it's back and forth. So this is a responsibility for the public health as well, to make sure that when they do this sewage treatment and they have this landfill, because if you know a little bit of that water supply, right, even for the lake water, so it has to be processed in a way there should not be a level of course, we talked about enterococci when we talked about bacteria, but they want to make sure that it doesn't have enteroviruses as well. But they are very small. The size of it is very small, and they are naked. The other set of population who may get this high incidence infection are people consume raw shellfish. So I'm pretty sure I was told, especially in California, there's a very high incidence among some ethnic groups where people want to take uncooked or half-cooked or raw shellfish. Okay, and then it has recently become a kind of a very popular type of food as well, where people want to consume raw food. If you look at electron microscope, this is how it looks like. Icosahedral, so it is like 8 sites. Very small. This is a typical poliovirus. Transmission, as I said earlier, you have to be very careful for your hygiene, and especially in daycare center, when you come across babies, you have to be very sure about the water and food you're consuming. And once you come in contact with people, you have to be careful. For enterovirus, keep in mind that I don't want you to get confused, because it is an enterovirus, but the portal of entry is mouth, and the mouth has connection with pharynx. So nothing stops this virus from going to respiratory system. And I gave you the example last year, enterovirus 68, most of the time, especially babies, show respiratory symptoms and not GIT symptoms. So as a health professional, I would want to know who are the people at risk. Young children are always at risk. And then again, people who have not been vaccinated for polio. So that they think the biggest success in medical history, if somebody was to ask you what is the biggest cure, so to speak, there's no cure in medicine, but if there was any cure in the medicine, that's polio vaccine. Polio vaccine has been considered as the pinnacle or hallmark of medical success. Okay? And then again, newborns and neonates are also susceptible to Coxsackie virus. Let me give you a little bit of historical perspective for polio virus, so at least you know why do we give them that kind of a honor. So polio is there in unvaccinated people, but I'm going to give you some statistics. There are still people, WHO is trying, they are out there. There is a group of people who believe that they should not get vaccinated. And there's also a conspiracy theory as well, which may be partly true. I'm going to discuss that, where people will think that polio vaccine itself causes polio. So there's kind of a misinformation there. So they want to resist that. Okay? But if there was to be a polio, it comes in 4 different forms. It could be asymptomatic. So we may have polio without knowing it. And then it could be abortive poliomyelitis, which is called minor illness, again 5%. Non-paralytic poliomyelitis, we call aseptic meningitis. And the major illness that happens right now, very rarely. Right now, very rarely. But if you go back and look at the history, I'm going to give you the examples where there was a big nightmare at that time. I want you to understand the pathogenesis of most of the viruses when the viruses go into your brain. When the viruses have an affinity to go to your nervous system. That's why they cause pain. Polio, it basically goes into the blood from your intestine and lodges into anterior horn cells of spinal cord and motor cortex of the brain. So these are the 2 areas that these lodge into. And that's why they cause neuronal infection and paralysis. So that's an important thing to do. It depends upon where, if they go to your spine, you may have spinal paralysis depending upon the nerve supply. If it goes to your respiratory center, especially in cranial paralysis, we call bulbar paralysis, then it's going to affect the medullary respiratory center. So that was a major issue even in countries like United States in 1952. And I'm going to give you some pictures to give you an idea of what was happening at that time. And you can see from here, this is how the polio ward used to look like. Because if your muscles of the respiration are paralyzed, you need an artificial lung because they're going to expire. And then again, a typical picture still now is the latest picture from India and Africa. So you can see, you still see people with these kind of disability even today. And then again, this is a quiz for you. One of the presidents of the United States himself was a polio patient. Okay. Now, lungs are the most important thing. Even if you get paralysis, like this paralysis of the limb, still you can survive. One limb or two limb. But if you have paralysis of the respiratory muscles, then you are in big trouble. So this was an ICU unit in 1950s in USA. So you can see people were put into these kind of beds because of the respiratory, it's called iron lungs. They still exist historically, but you can imagine with all these young children being exposed in early 1950s. So there was a huge cry and a lot of information being delivered to the people, because one of the problems you have to have for viral infection is this lack of education. That's number one. Number two, there's a denial phase. Many times people take it easy. And I'm going to talk about that. I'm not going to overscare you, but you just be, I think the best option is be cautious. Go for the cautious. Don't go for the too extreme. You don't want you to become paranoid. As many of my friends were physicians, and you talk to them, they would never jump into the, I give an example, into the public swimming pool. They would rather have a swimming pool in their home and pay price for it, or never use the linen and towels of hotel, no matter how 5 or 6 star the hotels are. The other extreme is, of course, carelessness. So that's again not good for people who are in health-related fields. So you should make your own judgments. These are the muscles that normally get affected, and you will see the whole idea is that there is contracture. So the typical aftermath of polio infection is you will see these people having contractures. So you can see they will be unable to straighten the knee. So they have like contractual kind of paralysis as compared to spastic that you may see, for example, in tetanus. So this is more of a contracture. So even you see today, you can see from this special child that you cannot bend the hip or bend the joint. So you will see that kind of an activity. So if you see them walking, they need to use those crutches because of the contractures that we normally see. Now, this is what we need to know in epidemiology. Is it still there? Well, the answer is yes. And vaccination programs are there, and we are still trying. And again, as I said, I just picked up, you will not see in your old slide, I just picked up this information data this morning. And you can see from here, this 2012 polio cases worldwide. So we had like 2,000 cases being reported in 96, 98, and we still had, I would say that, endemic. So they're always there. It's not been eradicated fully, but even in 2012, 2013, a couple of cases here and there. WHO is really, really interested in that, and they want to maintain, and this is what I found out this morning. This is the data they had on their website today. 2012, 162 cases were reported, and you can see it's come from China, Pakistan, India, Afghanistan, and whole Africa. So there still are cases over there. And of course, lack of proper drinking water. But the point is that many of people from this area are going to travel. There's no travel restriction for you to show them that you've been vaccinated for polio as of today, as I understand. Okay, they may have it for Ebola. I don't know whether they do or not, but that's what it is. Okay, so you see, virus is still out there, the polio virus. Now, this is a incident rate from 1912 to 1970. I just want you to pay attention because this was the challenge historically in USA, for example. So we had the World War started, 1914 World War I. And then again, you can see from here, there was an issue of the public health where they found out, especially in New York City, for example, this is a test from New York City, we had 75% increase of the polio virus. And they wanted to find out where is it coming from, how we need to treat the water, how do we need to clean the washrooms, how do we need to, many things are there, and they were very important. So they came up with many different ideas. And then again, there was a big struggle, what to do, what not to do. And luckily, they, in the whole process from 1912 to 1935, they made a polio vaccine. So they made polio vaccines. And again, even beginning of the World War II, so you can imagine the Cold War, you can imagine the resistance the Americans would have to anything that's coming from Russia. And what so happened was the biggest success story that we got in medicine, the discovery of polio was by Russian immunologists, nobody else. So they also were very cautious to take anything from them because they would have thought that they may have something that's going to kill the whole nation, so to speak. But you can see the resistance over there. And at that time, they developed DDT and many pesticides to want to make sure that they can clean the water and so on and so forth. So public awareness. And again, in a war-torn country after the World War II, you want, and imagine, I'm pretty sure that you yourself will have trouble in realizing if mom was to be told that I'm going to give to your newborn, a neonate, a vaccine that contains a live virus. So that was a challenge. And with this make-believe that is going to help your child. You can imagine the public education that was required at that time. Okay? And you can see from here, they look at the statistical things all over the world. You saw in Germany, even in different parts of the world, whole world is facing a big problem where polio is rampant, virus is running amok, and you have nothing else to do but to come up with an idea. And when the first vaccine was made, at that time, as I said, it was a live attenuated vaccine. And then again, most of, especially for US policymakers, they always are towards the safe side. So they were very, very reluctant. Firstly, it was coming from Russia. Second thing, because you want to educate the people that we're going to give you a virus. What if this virus itself causes disease? So that's a big challenge. That's a big, just like, I mean, just think like now that if I was to develop, not me, or develop a vaccine against HIV, I tell you, hey guys, I'm going to give an HIV, you're going to be protected from HIV. How many of you are going to be willing to take an HIV? So that's a challenge at that time. Though I'm not going to talk, I'll talk about that to my research students, that they are thinking that if you give HIV to some of the cancer patient, that's protective. So these are some of the clinical studies happening right now as we speak. So last week's big news, they used a virus, because virus goes after the cells, you know that. And if they are cancer cell, you just educate that particular virus, especially adenovirus, and just code it, it's going to go for that particular cancer. So this is going to be like a new drug development in future, and it's been run as a clinical trial. Okay? So anyway, so I'm pretty sure you understand the need for the public education and the right information. That's another thing. Now, again, I got this morning, this status like this morning, and again, you can see there are still, especially, this is from CDC. CDC thinks that it's talking about vaccine-associated problems. So in the next 20 years, they think especially there's going to be a big change in health industry because the old vaccines are not working. I don't know how many of you hear about that. We had this compliance that I've been vaccinated for polio, I've been vaccinated for MMR, measles, mumps, rubella, and all these things, so I'm okay. Things are changing. There's a new line of development. We're thinking that we have to come up with new vaccines, new antibodies. There's going to be enormous scope for people who want to go in industry and go for especially immunological-based vaccines, because we are seeing something that we didn't used to see before. Whooping cough is coming back, diphtheria is coming back. We have still, you're talking about the associated, vaccine-associated problem, because by the end of the day, you have to ask yourself, is a live attenuated virus? How much you want to attenuate it, kill it, so that your body sees an antigen and doesn't cause the disease. That's the whole idea. Okay? So WHO tries to aware the people, to give them proper information, and I think it's a part of your job as a pharmacist as well. You should know. I mean, if you are there in CVS or Walgreens and somebody, senior citizens come or anybody comes, say, can I take this vaccine, the shingles vaccine, for example? So you should at least know what it's going to do. Is it a live, or it is an antibody, or what is it? Is it going to protect you from, what is it going to protect you from? Is it a herpes zoster virus, or what is it? We talked about it yesterday, right? Huh? No? The thing is that once you got chicken pox, you pretty much are immune to it. Either you get a chicken pox or you get a vaccine. So you will never have that again. But again, having said that, we are still coming up with problems when the vaccines are failing. So that's where the challenge is. Or, I don't want to say that, but the other thing will be the virus is mutating. So there always be on a safety line. You have to be very, very careful. But anyway, public awareness was important at the time. Even United States government wanted to recruit people like, you see, celebrities, they themselves getting vaccinated to make people feel that it's okay, you can do that. And a lot of media attention. They wanted to kill these perceptions that it's not controversial, it's okay. The president himself is there, if you remember him, and he's there. So they want to create that awareness among the people with very sound basis for information. And the control, again, as I said earlier, live oral polio vaccine, which is there. And the other chance is that you may have an inactivated trivalent polio vaccine. For all other enteroviruses, there's no vaccine because, as I said, Sabin and Salk, so these are the two scientists who developed this vaccine. Since there is a chance of live vaccine-associated paralytic poliomyelitis, the killed one is permitted in this country. So we don't give attenuated, so we don't give Sabin, we give Salk. So that's the difference. The VIVA's recommendation in terms of CDC. That make sense? Okay? Because remember, immunologically, which one do you think would have been better? A killed one or live attenuated? Live attenuated would have been better. Because your immune system learns how to deal with it. Right? But again, if you look at the problems, it's better to go for the killed one and not get that challenge. The other RNA viruses called rhinoviruses that you normally see common cold. And then again, I want you to keep in mind, common cold is not flu. We may use, I just use stomach flu, that's the wrong word, layman word. It's not flu. Common cold is common cold. Most of them are basically rhinoviruses. And the good news is that you must have heard they're going to complete the cycle, and there are many self-limited, so it should not cause a serious disease. So there's no need for us to do anything. The only thing the drug companies may be doing is that they are developing, since it is 80% of the rhinoviruses, they wanted to mute that ICAM receptor that the ICAM receptor this virus goes and clings onto. So if you look at the pictures, for example, over here, you will see that this is an ICAM molecule over here, ICAM molecule. So that's where the virus gets attached to. So if you block that ICAM molecule, the first step of viral entry attachment will be blocked. And then again, it's used as an antiviral therapy. For pathogenesis, again, if you compare rhinoviruses with enteroviruses, as the name suggests, they cannot withstand the environment of gastrointestinal tract because they are labile to acidic pH. So they're going to get killed. So they want to grow at 33 degrees C, more or less the respiratory area. And then again, the important thing for this particular virus is that it's very infectious. So if you are sitting next to a person who has common cold, all you need to do is you just need one particle of the virus. That's good enough. You can see infection can be initiated. And depending upon what kind of severity you have, that depends upon the load of virus you have. So sometimes you have a higher load of virus. That again will determine what kind of disease you have, or how your immune system finds it to fight with. So those are some of the players that you have, the load of the virus and your immune system, and that's the fight that goes on between you. And many a time the immune response basically is a response which is pro-inflammatory. And again, if you remember your immunology, we call running nose, so rhinorrhea. So that's basically because of the release of histamine. That's why the common over-the-counter medicine for common cold is antihistaminics. That's where it is coming from. Okay. The other important thing is that if you remember your basic immunology, interferons are required to upregulate immune response. So you can give interferons to the people, but very expensive, unless and until immune system is really messed up or very much compromised. The other important thing is that you have an IgA antibody sitting as a protective antibody on the mucosa. If you do not have that protective antibody, then again you may be prone to these kind of viruses over and over again. So this particular common cold is not an index of how good your cell-mediated immunity is. This particularly is good enough to tell how good is your humoral immunity, how good are your antibodies. So that's basically the major difference that you may have between this particular virus as compared to enterovirus, and both of them are RNA. Again, you can see the viral pathogenesis as we talk about respiratory epithelium, viral entry. So this is what I meant when I said cell-to-cell lateral infection. So you can see the virus enters into the cell and then laterally enters to the other cell. It doesn't jump out into circulation or extracellular fluid. So it would not seed an antibody. So that's a virulence mechanism that this virus has picked up. So it's going to go pass it on to the next cell and cause cell death, and would never be exposed unless and until it goes and kills the cell and is released. And if you compare that in terms of like bacterium, so if you want to compare bacterial pathogenesis as compared to viral pathogenesis, bacteria would not do that because it's larger in size. What bacteria may do is that bacteria can release toxins and enzymes. They can go paracellular route. But viruses, many a time, so if you see a skin lesion, for example, I told you the cold sore, so it's like a localized thing. So it causes damage, it kind of spreads out, like a ripple effect. You throw a stone in the water, it's a ripple effect. And the technical word for that is cytolysis, syncytia formation. So if I was to take like scraping from your skin lesion and look at the cell, I'm going to see cells which are joined together in a syncytium, and they're all killed by these viruses. Okay, and many a time when we take the viral culture, we have to grow them on kidney monkey cells, the monkey kidney cells, because that's where they grow. They have to have some media there. The clinical syndromes basically, as I said, that it will be tough for you, and you don't need to do, if you get respiratory illness because of enterovirus, or you got from rhinovirus, you cannot basically tell the difference. And you don't need to tell the difference unless and until if there is a specific outbreak of a particular virus. Okay? But there are clinical important things. And I said yesterday as well, if you call the school line, they're going to say if your child is sick and you think he's got a fever or flu-like, better keep it at home. So you want to be on the safe side. If you want to err on the safe side. So you want to take your more of a realistic picture, but I'll leave it on you. I'm going to show you some slide, but not necessarily, and I wouldn't advise you to do that because it's not that easy that you want to differentiate between cold and flu. Because there are, I'm pretty sure, even if you go to Walgreens, I went the other day, they do have these posters. And one of the posters I just picked up from there. And you can see it's from CDC, so it's authentic in terms of it's not coming from the drug company who want to sell the vaccine or drug company who want to sell the medicine. And you can see flu is often confused with common cold, but flu symptoms develop more quickly and more severely. So this is a message. They're very fast and very quick. So you can see if you have a cold on the left side, if you look at headache is more achy in flu. Running nose is less. Soreness is basically may or may not be there in flu. Chest, they have a dry cough. Appetite is decreased. That's very important for flu virus. The appetite is when there are three important things in viral infection that tell you whether you're improving or deteriorating. Right? Number 1, nausea. Number 2, pain. Number 3, appetite. Because the moment you get viral infection, if you're getting all these things, you are on the downhill. And when these things start improving, you have less nausea, less pain, and you have desired appetite increases, there's a recovery phase, convalescent phase. So that's important. That is basically, if your body was to send a message, you are okay. Remember, it's a physiological homeostatic mechanism. So you'll go to work, you go to school, you want to exert yourself. Body doesn't want you to do that because fighting off a virus infection, so it's going to make you sit. It's going to make you lie down. And this is what body does. Creates the pain, creates the nausea, and creates lack of appetite. So then you feel that I'm sick. I need rest. So that kind of a feeling is a homeostatic feeling from the body telling your body is telling you you need rest. Does that make sense? I usually say that you may have heard that don't fight your immune system, you're not going to win, right? That's what it is. Okay. Muscles are more achy in flu. Onset is sudden. Body temperature, that's why when you remember flu outbreak they had this on the airport taking temperature for everybody who was boarding the plane. You have very high temperature in flu as compared to body. And then again, fatigue, it kills you. Flu, those of you, none of you, but it really, really debilitates you. Even if you are a very active athlete, it's going to kill you. That's what it is. So people, even if they're young, they end up in hospital because flu is serious. And the problem is that if you are strong enough, what about the kids? That's what the problem is. And again, there are many other slides. I'll leave it on you to look at. And I picked up quite a few from different sources. But the message is the same. The other important thing I want to give over here is that the H1N1 story, I'm going to build up that story today because I want to talk about that on Monday. Because rhinovirus didn't have a very defined envelope. So I didn't talk about H1N1. But once we talk about those glycoproteins layer, then I'm going to talk about the Tamiflu. But as of now, it stands as that again, you can see the other spin to that is, and I'm not going to ask you to do that, difference between flu and common cold. You may have realized you can pretty much do it. The other challenge that we have for pediatricians and immunologists is how would you differentiate between common cold and allergy? That's another challenge because everything gets confused. You can see from here, many a time if you compare them, there are hardly anything. But if there is anything, guess what? That's coming in an exam. You can see from here difference between cold and allergy. You can see journal aches and pains, never in allergy. And if you look at fever, never an allergy. So these are some of the things that you should have in your mind if you were to make that kind of a distinction. Again, a long slide, allergy, cold, and sinus problem, because sinus problem, again, is very common in this country. It's so much common, especially when I was in Loyola Medical Center, that we had our allergy, immunology, and ENT lumped as one department. So they know most of the problems that people have in this part of the world are sinusitis. The headaches that you got is sinusital headaches. Because if you know your anatomy, there are potential spaces in your head. There are potential sinuses, maxillary sinus, ethmoid sinus, frontal sinuses. They're huge cavities, and they get inflamed. And when they get inflamed, then you got tension headaches and so on and so forth. Okay, just give me one more minute and I'll be done. So for the lab diagnosis, unnecessary. They don't need to do that. And then because who would want to go for a lab test, especially for common cold, right? But all other viruses that we discuss, herpes virus, herpes zoster virus, all these bigger polio virus, you have to have a lab diagnosis. That's serious and has to be done, okay? And then as far as treatment is concerned, over-the-counter remedies are available. No antiviral drugs. You should not give antiviral drug for common cold, right? As I said, intranasal administration interferon can be given to block infection for activity, but the question I'm going to ask you for the common cold is that why is it that rhinovirus that causes common cold is not a good candidate for vaccine? The answer for that is because it has multiple serotypes, right? And then again, the benefit, this is how it works. The drug industry wants to make a vaccine if it's really a need to do that. So they will look at statistics. For example, they will look at statistics. I told you yesterday, 100% of the population in this country or the world will have an HPV infection. So there's a good chance for the drug company not only to manufacture a vaccine, but to sell it as well. As compared to if they were to come with an ICAM-1 blocker, you get like 10, some people get like 10 bouts of cold, or everybody gets a cold, so you don't care. So there's no point having you being vaccinated for that. Then CDC is the one that basically determines. Remember I told you they started, 12 years was an age they wanted to give vaccination for girls, young girls, HPV. But when they looked at the incidence, they were like 11-year age girls, they were pregnant. So they had to come back to an age where they want to do at age 11. Then they thought it was only for girls. This data showed no, it's because girls have partners. So boys, so they want to vaccinate both. So there are very tight CDC regulations for all vaccinations. And then they also have recommendations, okay, based upon the scientific evidence, and they keep on changing. I gave you yesterday's example. For example, for shingles, 2006, it was only meant for 60 and above. 2011, they said, let's add another 10 years, 50 to 60. So these are tightly regulated. And the reason is because this is a live virus. You want to give a live virus to somebody, and it flare-ups and cause more problem, and then litigation and sue and so on and so forth. Okay? So I'll stop here, and I'm just going to give you a warning that I'm going to have a very important topic on Monday, influenza. So please read that lecture ahead of me so we can benefit from that. And thank you.